welcome back to another episode of Between Sessions with Berries. We have a super cool guest today. Her name is Claire Ellerbrock. She's a psychiatric nurse practitioner in Columbus, Ohio. Claire found that while her graduate program provided her with a degree to practice, she could have benefited more from more clinical guidance to confidently enter practice treating complex patients. Yes, all of us, I think, feel that way. This realization led her to create Stress Free Psych NP. I love the name of that. It's an online educational platform that guides both new and experienced psychiatric and family nurse practitioners to more confidently and competently treat their patients with mental health needs. Claire, welcome. I love that you're here. So excited to hear about you and your story and everything that you created. Could we start out and just give everyone a little bit of a background about you and sort of how you got to this place?
Absolutely. Yeah. First, thanks so much for having me. Really excited to be here.
You're welcome.
So yeah, I'm a Psych NP. I've been in practice going on 8 years now. Live in Columbus with my husband, Matt, and we're actually expecting our first little one in August. And so we'll be getting my biggest promotion to date soon. But my background closely ties to how I got to doing what I do today, which is advocating for other NPs. I wasn't someone who always knew they wanted to work in healthcare or be a nurse or a nurse practitioner. In college, I went to Washington University in St. Louis, and I was very interested in human behavior and psychology. And I spent many summers working as a research assistant at the university's psychology department. And so I thought I wanted to go sort of the clinical research route in some capacity. But over time, I realized I wanted to have a more direct impact on outcomes and interact more with others. And so that led me to pivot to a career in nursing. And so I moved cross country after college and got a degree in nursing, followed by my master's to become a Psych NP. And I worked really hard in school, as many do. And I was just incredibly eager to be the best provider I could be entering practice. But when I did enter practice, it was a really tough transition. I was working in community mental health, working in an outpatient setting and on a crisis stabilization unit. And I was just seeing really complicated patients.
Yes. Oh my gosh. The most complicated, I would say. Yeah.
Yeah.
Gosh.
Clinical support was limited. The volume of patients I saw was high. I learned a lot in those first 2 years, but it was sort of a trial by fire experience, seeing patients with depression and anxiety, but also more complicated ones like schizophrenia and managing patients on complicated clozapine regimens and slowly tapering patients off of dangerous doses of benzos or consulting with a therapist on mutual patients with complex PTSD. And so looking back, I'm not sure I would have done anything different as a student in school. I just didn't feel prepared for practice. That was really tough. And after 2 years, I was very much questioning my decision to have become a Psych NP. I had 6 figures of debt and a lot of stress. And so sort of, I can share a little bit more where that went from there, but that was sort of the intro into kind of.
I'm relating to you so much because, I mean, even with therapists, we have the same thing. We get out of grad school or whatever, and it's like the first stop is like community mental health, which is the most acute. I mean, and the biopsychosocial piece of it. You might have some homeless clients or, clients between homes or not med compliant or can't get their meds, no transportation. It's so hard. And we're like brand new in the field. So it is so complicated and stressful. I can really relate to what you're saying for sure. Trial by fire kind of thing. Like they just throw you in. Yeah.
It really is. And it shouldn't be that way because it's the most sort of vulnerable population.
It's backwards.
Tough. It is. And I love it. And it's interestingly my favorite community to work with. But just out of school, it was difficult. I actually, I sought out weekly clinical supervision sort of on my own. I had met a psychiatrist on one of my clinical rotations in school, and he graciously met with me every Saturday to review cases and answer questions I had, which was super helpful. But after talking with other NPs, though, I realized my experience wasn't unique, and it sounds like it's the case for therapists also. And so I was looking around for other support resources in addition to the supervision. I wasn't finding anything. I think either they were really expensive or they didn't exist or they weren't really helpful. And so over time, that led me to create something that filled this necessary gap in nursing education. And that led me to create Stress Free Psych NP and the resources I offer.
I love that. I want to deep dive into everything that you offer with that. And I'm assuming part of it, and we kind of talked about this before we hit record, was how do you effectively assess? How do you diagnose? How do you treat complex patients and do that in a short amount of time? And I'm guessing your platform or your resources helps teach that type of thing to somebody that's like maybe just starting out or just needs this extra level of support. like we all do, to be able to do this effectively. So maybe we could just talk about that some. Like, how do you do that, especially as a nurse practitioner? Because, oh my gosh.
Yeah, I mean, I think it's provided our time is limited with patients. Often, we're seeing patients back to back all day with limited time for admin or breaks. Again, I think it's similar with therapists also. And in mental health care in particular, I think cases aren't always black and white. There are shades of gray. Not every presenting patient looks the same, and treatment for one patient with the disorder might not look the same as another patient with that same disorder. And so while we can't standardize how our patients will present, I believe we can standardize how we approach each patient. And so adding more structure to unpredictability, and that's through a really systematic framework of assess, diagnose, and then treat. I think it's deceptively simple, but I think it's not always done or steps get skipped. For example, a patient might present with various complicated symptoms. And instead of following this framework, we might jump to prescribing medications that are really symptom-based instead of diagnosis-based. And that's a problem because it leads our patients, down a road of polypharmacy and not necessarily addressing the underlying disorder. And so while it can be time-intensive upfront, I think spending time gathering, assessment data, sometimes over multiple sessions, and then developing a diagnosis or differentials, and then formulating a treatment plan saves patients time and you time long term. But I think we're so easy to jump to prescribing at that first visit, thinking that we need to help the patient right away. And sometimes that doesn't always happen.
I love that approach. Yeah, because I imagine they're coming to you too, like expecting to get a medication to just maybe like put a Band-Aid on even maybe like a psychosocial issue instead of like actually an issue that requires medication, I would guess.
Absolutely. And I think we come into this field to be helpful also. And so there's a strong desire to help. And I think, when I mention this framework, it sounds very simple, and it's actually, I think, harder to execute, to really spend the time up front to make sure that we have all the information we need to then formulate a diagnosis, to then come up with a treatment plan, which may or may not involve medication. Sometimes it's therapy. But I have a free training that walks through the framework with case study examples to kind of show it more concretely. But I definitely think this helps us save time in the long run by making sure that we're systematic, because mental health is a little unpredictable and gray, and you don't know what you're going to come across. But if we have a standard approach, that can help us have a bit more structure in our chaotic days.
I love that. And I think we have the link to the free training too that we'll put in the show notes for anybody that wants to download that and take the free training.
Perfect.
Yeah, because I would imagine there's maybe some pressure that a nurse practitioner might feel if somebody comes into your office that day to have them leave with some sort of medication. And what I'm hearing you say is you're almost giving permission to say it's okay to assess over a couple of sessions and figure out what exactly is going on before you just jump right into that medication regimen and put them on a med and then maybe see them in 6 months or whatever. Not that you would do that, but, I think that's the conception out there sometimes with doctors or nurse practitioners, to just like, okay, here's your Lexapro, come back in 3 months and tell me how it's going, that kind of thing.
Sure. Especially I think when you're a new grad also, there's thoughts that you need to do that. And I think you're doing so much at the first visit. You're collecting all this information, you're developing a diagnosis. You might obtain collateral information from a previous provider or hospital records, or talk to their therapist, or get labs and an EKG that are baseline. And so you're doing a whole lot at that session. And so I think releasing pressure to prescribe is something that we all need to be reminded of, I think, over time.
And then how do you structure that time? I mean, that was kind of in that like multi-part question that I asked, but for therapists, right, we're kind of like bound to this 53-minute session. And I feel like nurse practitioners are probably even bound to a tighter schedule, maybe like 15 or 30 minutes. And maybe you have to get like 20 people in a day. I don't know. But do you go into your practice with like boundaries around that stuff and how you're going to run it? And I'm assuming you teach this stuff too. But do you have like tips around that, like the time management for the pressures, I guess, of insurance companies and society and all of that to like adhere to these quick appointments, like get them in and get them out kind of thing? Do you have tips around that, or how do you manage that?
I think it depends on the setting. I own my own practice. I've done telehealth. I've done community mental health and PHP programs and eating disorder. I think it depends on the setting. Standard, ideally, is a 60-minute session that can be sort of broken up. But I've worked at places where you have 45, which is wild because you're getting a lot less information in that time. And patients, don't always answer questions as succinctly as we would like, or don't always show up on time, and you're kind of working around those constraints. So I think the biggest tip is to make sure that you know that you don't have to get everything at that first visit. you're hitting on certain buckets of categories of, what's bringing you here and doing your HPI and then getting past psych history and substance use and medical history, hitting all of those. But if we're not completing everything, we don't need to rush to the next step. It's sort of a paying attention to the clock. But if, we're running out and this patient's very complicated with a lot going on, we're kind of wrapping up by kind of summarizing that we'll pick up where we left off next session, and maybe getting some labs and some other records to help fill in some gaps can be helpful. But I think the worst we can do is just to rush to collect all the information or leave things missing and jump ahead to the next step.
So what's a script, like for a new nurse practitioner that might be listening, like a script that you would say to a client that's like, can you just give me some medicine? How do you like easily say, we're not doing that yet, we're going to sit with this for a little bit? How do you manage that part? I'm curious.
I think being incredibly transparent with, let's see, so saying something along the lines, if we're wanting to maybe gather more information or if they're complicated, that, I want to get more information and make sure that we have the right diagnosis before prescribing medications, because if we don't have that, then we'll go down a track of trial and error with many different medications, and you'll get frustrated because you're not feeling better and get discouraged. And so to avoid that, if we collect more information, take more time to make sure that I have everything that I need before proceeding, it's going to be better long-term for you and health and frustration-wise. I find that patients often appreciate the diligence in prioritizing the quality of care also. And so just acknowledging the time constraints and in your desire to be more thorough with the information you're collecting before proceeding is appreciated. And just highlighting again that we don't need to trial and error a bunch of things many times over again, which is what we would be doing if we're jumping ahead too quickly.
Oh, yes. And then I would imagine starting somebody on medication and then having to switch and, like trial and error on different medications. Like there's a whole like getting on the meds and then getting off the meds and transitions and all of that. So it does seem like it would ultimately be a huge time saver to wait and take your time with it. Yeah.
Easier said than done.
Yeah.
But yes.
Exactly. So another thing that you talk about some is just like documentation and charting tips and that sort of thing. Could you touch on that a little bit, like how you manage that and what advice you'd have around that topic?
I think my biggest tip is using what's called the HPI one-liner, History Presenting Illness one-liner. Can't take credit for it, but when I was a brand new NP, my brother, who's a psychiatrist and did his residency at Harvard, taught me this tip with documentation. And so it's a single sentence that tells a busy provider everything they need to know right up front, so that in follow-up visits or when patients start to blur together, as they often do, this sentence is a great summary to keep you grounded. And so the structure is patient or name is a blank-year-old, insert their gender with history of past psychiatric history, medical history, substance use disorder history, include other relevant history relevant to your specialty, who presents for either an initial psychiatric evaluation or med management follow-up. And some more concrete example of that would be Mr. Smith is a 40-year-old male with history of major depressive disorder and alcohol use disorder in remission, past medical history of asthma and type 2 diabetes, no past psychiatric history or suicide attempts, who presents for an initial psychiatric evaluation. So the components, the fill in the blank, are filled in after the session, because obviously you don't know that before seeing the patient. But in follow-up visits, having this one-liner at the top of your note or in the plan section can be a really great summary to have. And it's been something that's been really helpful for me, where I don't have the most amazing memory, and seeing lots of patients back to back, it really gives you the succinct, important information to take a peek back at. And I found it helpful, and other providers taking over my caseload can take a look at that too and have a really succinct summary at the top.
That's awesome.
So,
yeah. And then if you have to come back, if you have a busy day or back to back, you can come back and be like, oh yeah, okay, I remember what we talked about.
Yeah. I've just found that sort of summary to kind of be a great segue into the details of a note.
Absolutely. Yes. Oh, yeah. So tell us about Stress Free Psych NP and all of its components, because I know you have a course and you have a lot of free things that you offer, resources around. You kind of said how it came about, but what is it now? What does it evolve to? And how does it help nurse practitioners? I'd love to just dive into it.
Yeah. So my primary resource is a crash course called the Mental Disorders Crash Course, and it's an AANP accredited course for Psych NP students, new grads. Also, I have a decent amount of family nurse practitioners who are going back to school to get their psych certificates. And it's for these providers interested in learning more about diagnosing and treating mental disorders to boost confidence and competence in practice. It's a series of self-paced videos and cheat sheets, and it comes with an active community of over 200 NPs to discuss clinical cases. And I bring on guest speakers to discuss areas of their expertise. Deprescribing was a topic 1 month, and diagnosing adult ADHD has been an ongoing topic, and eating disorders. The course is sort of a combination of everything I wish I had when I was a student and new grad that I didn't have. And so it's broken out by different disorders. One module is on depression and bipolar, anxiety disorders, psychotic disorders, post-acute withdrawal syndrome, adult ADHD. And within those are individual disorders. And that follows that framework of assess, diagnose, treat. And so it walks you through each of those stages. And I think it's been something that fills a need that doesn't really exist to help supplement a provider in practice. And then I also have several free resources. One of them is that free training and templates to sort of supplement practice.
Yeah, amazing. Gosh, I bet it is so helpful.
Thanks. I've had a few hundred people go through it, and I think the community is a really valuable aspect because I think sometimes going from nurse to nurse practitioner, one of the biggest shifts I think is lack of sort of a community or team. You're working sort of in a silo, you in your office with the patient. Whereas as a nurse, you have the nursing unit and other nurses interacting with one another. And so I think something that we don't always realize entering practice is that the support really drops off quite a bit. And so having a community inside my course is important to allow providers to engage with one another and validate each other's experiences and discuss clinical cases.
Yes. So what is a trend you're seeing right now? I feel like I'm seeing neurodivergence all over the place. And I'm just curious, you all would be the ones we would turn to for help and support around some of these issues like ADD and, autism. Autism's such a bigger spectrum now and the things associated with it. So just wonder, like, in your position right now, and then working with all these other NPs through your program, what's coming up most right now for people? What are the NPs treating and most puzzled about it? And, how are you guys managing all that? I'd just be really curious to hear about that.
Yeah, there's a couple disorders. First, you had mentioned, ADHD, particularly in adults. I think we're seeing an uptick for many reasons. I think one of them is it's being recognized more and diagnosed more, in which case it's being treated more. And NPs don't get the most education on, assessing for ADHD, especially in adults. There's actually not any, as of 2025, there's no clinical practice guidelines, universal guidelines for diagnosing adult ADHD, which makes it even more complicated.
I didn't know that. Wow. That's amazing.
In process of being developed, but right now we follow kids' diagnostic guidelines in the DSM, and adults are very different. We're not running around our office at work. That's not really how ADHD manifests in an adult. And then in an adult woman, ADHD is even more complicated and misunderstood. And so I would say that's an area that comes up quite a bit. For me, in my practice, I'm often referring to a therapist who's trained specifically with ADHD because that's not my area of expertise, but I would say that comes up a lot. And then bipolar disorder and differentiating what's called unipolar depression, like just major depressive disorder, from bipolar depression. There's a lot of overlap between the two, and it can be tough to differentiate the two, and treatments look quite different. And so I would say that's another area that clinicians often have a lot of questions surrounding.
Yeah, I would imagine that comes up a lot in your community, just trying to get support around making decisions around that stuff, especially if you don't even have a protocol for adult ADD or ADHD to diagnose. That's so interesting. I had no idea.
It's a challenge. And I think as it becomes more popular, people come in wanting assessment for it. But if we don't have clear guidelines or understanding of how to do it, it can get very messy for a clinician pretty quickly.
Absolutely. I think for therapists too. I always see that coming up, like in therapist forums, like, how do I get an assessment for these people? I'm seeing this and I don't know what to do or how to help them manage it. And of course, the first thought is like Ritalin, right? Or some sort of medication to help them manage it better. But, I'm guessing y'all take in the lifestyle account, like being on your phone all the time, like all those things that are just so overstimulating already. I would think that it's just so biopsychosocial with even that diagnosis. Yeah.
Sure, and making sure it's not something else. Other disorders can look like it. And then again, it presents differently in females compared to males. And so there's a lot of complexity surrounding it.
What is the difference? I'm just curious, what is the difference in male and female with ADD?
So especially for adults, it can look a lot more like So in male, this focal sort of presentation is a hyperactivity, sort of running around, impulsive. And in females, it doesn't always present that way. There can be a lot more daydreaming or emotional dysregulation or perfectionism involved. And because we don't have tools that let us systematically assess for it just period, it can be missed pretty quickly. Especially, I guess, going back to like little ones also is who I'm thinking of, like a young boy versus a young girl. Young boys will often be pointed out for being disruptive in class and running around and being disruptive, and females, whether it's socialization or not, can present as quieter. And there's just a lot more going on internally that doesn't necessarily get picked up. And so it's easy to miss signs of the disorder.
So interesting. Yeah, I know so many people that have later in life been diagnosed, and they're like, it changed my life knowing I have this diagnosis.
Absolutely.
Mhm.
Absolutely.
And how quickly would you treat that with medication? I'm just always so curious about that because, I hear different things, that lifestyle management, or do you take medication for it? But then you also hear that it's literally a brain disorder, so medication should treat it. I just wonder your thoughts on that too, because I see that come up all the time.
That's such an interesting question. So first, it is a very, very hereditary disorder.
Okay.
And so if you have parents where one parent has ADHD and the other doesn't, your child has a 50% chance, give or take, of having the disorder. And so it's one of the most hereditary disorders in psychiatry, but it's also one of the most treatable. And so stimulants are first-line treatment for it for a person who truly has ADHD, along with learning behavioral techniques and skills management to help. And so sort of like the catchphrase with treatment is that pills don't give skills. And so just because someone with ADHD receives treatment with a stimulant for their ADHD, there's still other components that aren't being addressed by the medication. And so that are things like learning prioritization, of understanding of what needs to get done when, or learning how to address time blindness, where a person's working on an activity and they maybe at work and they're working on a project. What can happen is a person loses track of time and they're hours into the activity and still working on it. That's not something that the medication addresses. That's something that those skills that working with a therapist who's trained in ADHD skills management would be able to assist with. And so understanding that the medications are very important and they help with certain aspects of ADHD, but there's definitely a skills component that's required as well. And that treatment definitely requires the management of both.
Yeah. Wow. It's such an interesting topic. And I've heard you mention the therapist a lot of times, which I think is amazing, because I think as therapists, from our perspective, sometimes we don't know if the nurse practitioner or the psychiatrist wants us to reach out to them with like collateral information or to talk about what we're seeing on our end. So it's really cool to hear you talking about collaborating and using the therapist as a resource to help with all of this.
Always. I think we're only seeing you as well, only seeing a patient for a short snapshot of time. And so getting as much information from other providers in the team, I think is important. I think the team-based approach is essential. And I think time is the biggest limiting factor of talking to other providers for me with therapists, but I gather so much information from being able to bounce ideas off of the patient's therapist to get a sense of their perspective and make decisions together. I think there's no one expert. The patient is in that team also. They're an expert on their body and their experiences, and we each have expertise in our areas, whether it's meds or the talk therapy. And I think together we make a great team, but I think all pieces are essential to quality treatment.
It's so good to hear. We often talk a lot about like networking and marketing and all of that for therapists, and always just like reach out to the NPs in your area. They're a great resource to try to do networking and get more clients, but also collaborate on the case. Like just do that, reach out. So I'm really glad to hear that it's welcome and you're open to it. Yeah, that's very cool.
100%.
Do you talk about that in your
100%.
community, like the networking piece and the collaboration with other providers and that sort of thing?
A little bit.
Okay.
Yeah. Sometimes it's more across. There are some specialties where you're reaching out to them where they don't necessarily aren't as open to collaboration, I suppose. I'm thinking of, oftentimes I get baseline EKGs on patients. Some of the medications we prescribe can cause heart issues. And so getting a baseline EKG to look at heart functioning can be important. And sometimes when results don't look great, referring to primary care or cardiology is important. And, not all providers are receptive or have the time to field these consultation calls because we are so busy. And so navigating these conversations or what to do next when things aren't looking good and you need to consult with someone else, those conversations come up. Or as NPs, in certain states, we're required to have a collaborating psychiatrist to discuss cases or just to have as a part of a rule in states that don't have full scope of practice. And so conversations can surround asking questions to our collaborator and how to navigate that because they're not always available. And so those are sort of the types of conversations that come up surrounding collaboration in our community.
Yeah, that's amazing. Gosh, what a cool program you have. So, Claire, are there any clinical pearls of practice that you could share with the listeners that could help them?
Sure. Last year, I actually created a blog post that was a reflection of my journey as a Psych NP and 7 lessons I had learned over 7 years of practice.
Oh my gosh, amazing.
And looking back, I learned some valuable things over time, and I condensed those into 1 lesson per year that I can share if that might be helpful to your audience.
I would love that. Yes, please.
Awesome. So in 2018, I was a new grad, and the lesson I learned that year was that not all patients respond to the same medications, and patient presentations vary. So in school, we were seeing really textbook presentations, but in practice, patients don't always present the way they do in textbooks or the DSM. And so my first lesson was understanding the more gray aspects of mental health. In 2019, the lesson was that your employer doesn't always understand your role as a nurse practitioner. So actually, the first NP program was only created in 1965. So that was only 60 years ago. And so the scope of practice of NPs is not fully understood by the public or your employer always. I think part of that is because the profession is so new compared to, medicine that's been around for hundreds of years. And so I think understanding your scope of practice is really important. And that was the lesson I took away from 2019. 2020, the lesson was know when it's time to take a step back, attuning to your needs and kind of take a step back from work. For me, that was during the pandemic. There was a lot of difficulties of me working in the substance use disorder treatment setting and navigating patients there and protocols of COVID. And so definitely a time that was difficult for mental health providers too, managing patients who are also, having their own difficulties. In 2021, the lesson was setting boundaries and breaking the norm is key to longevity. And that was sort of my introduction to more non-traditional work as a nurse practitioner. I was doing work as a travel NP, doing what's called locum tenens work, where you take the place of another provider or practice that, has limited staff. And that was a really interesting experience, doing something that was a little bit different from the typical types of job the Psych NP might find. 2022, the lesson was patient's progress is not a reflection of how good of a provider you are. That was a tough one and still is a tough one for me.
I bet. Yes.
I think our goal is to help patients reach optimal health. And sometimes that might just look like helping a patient reach sobriety for for 7 days for the first time in their life. And that can be considered a win. And if a patient isn't doing well, that's not always because you're not an amazing provider.
I love that. I mean, that's such a hard lesson to learn too, because, especially when you're newer to it too, you think you could go in and just like fix everybody, and it can be so hard because you're like a small piece of what they deal with every day and who they deal with and their lifestyle and everything. And you can be the best clinician in the world, really. And it depends on what they do with that information. Yeah, it's really tough.
And there's so many factors. I mean, when I was new, person would come in with depression, I would prescribe an SSRI and they wouldn't get better. And over time, I actually thought it was me. And so I went and took a year-long CBT certification course to become certified in CBT so that I wasn't just providing med education, I was providing therapy education. And even that wasn't leading to better outcomes. And over time, I realized that, I'm part of it. But, the other part is, people can't always get to optimal health, but they can get to improved health. And that might look not the way you would expect or want it to. But like I mentioned with that patient I've had a patient who really struggled in sobriety. And with me, we got to a place where they were able to be sober for a week. And that was a huge milestone for them. And recognizing that as a win helped shift how I see progress. So that was the lesson then. In 2023, it was how you prescribe has as much of effect as what you prescribe. And I learned this attending a grand round psychiatry lecture. And I learned about the art of the science of pharmacology and learned the research behind the importance of the way we prescribe. And so communication skills like the tone we use, the rapport we build, the eye contact and confidence and education we provide patients, that all matters and it has an impact on care. And that was a really neat thing to learn, that 2 providers can both prescribe a patient Prozac, but outcomes can vary based on all of what I mentioned. That goes into how we prescribe, which I thought was really interesting.
Yeah, that's amazing. I'm sure it makes a huge difference. I'm dealing with my father right now in the medical system. And I can tell you, we've been in and out of the hospital, and the ones that come in and they're just super engaged and, really listening and repeating back and building that rapport, it's just helps so much to have that connection with the providers that are trying to help us. And it's amazing. And then you get the others that are, can't remember your name and they're scattered and maybe in and out and they can't remember what the case is about. I mean, it just makes such a difference to approach it that way. Yeah.
And learning that was wild to me because it definitely seemed like it was just only about the medication and what you're prescribing. And it's just very much not that way, which was really interesting to learn.
Yes.
Gosh. 2024, the lesson was that you're not a good fit for every patient, and that's okay. It's not always a personal reflection on you as a provider. Sometimes it is, and getting feedback is good, but that's not always the case. And it makes sense. Not everyone is a good fit for every person, and that's completely okay. In 2025, my lesson has been the more you learn, the more you realize you don't know. And, I haven't been doing this incredibly long, but the more I learn, the more I learn how complicated the mind is and mental health is. And we don't have all the answers. And I think the most dangerous providers are ones that think they do know everything. And so coming from a place of a learning mindset, I think is really key to being an exceptional provider. And so those are kind of some of the lessons I learned.
I agree. Yes. I remember a brand new clinician asked me, she was like, gosh, you seem so like you've got it all together. You just know what you're doing. And I was like, no, I don't. And I feel like if I ever do, like I'm going to be in trouble, like that's when your mindset is not good. I think when you're just like, oh, I know it all. I'm like, I've got this down, it just doesn't work that way. Yeah.
No, and I think it's also helpful to, at least for me, to reflect on things that I wished I had known when I was a new grad and what I would have done differently. I think one big thing is that there are things you don't need to do, especially on a first visit with a patient. We talked about this, but one of those is prescribing medications. I think another one is that knowing everything. You don't need to know everything at once, even though it looks like you might know everything. I think there's power and confidence and safety and not only not knowing everything, but also admitting or being okay that you don't know everything. Because how could we, whether we're experienced or new? Too much to know. And then the last thing I wish I had known starting out that I don't need to do is see patients back to back. It's a tough one because it's not like you can make patients wait all day and you definitely have a schedule to keep. But I found that taking a couple minutes between each patient helps you stay on top of charting. It's definitely been a lifesaver for me. And AI tools like Berries make this easier, but that didn't exist when I was starting out. And so taking that time between patients was helpful too.
Oh my gosh. If only I'd had Berries back to 20 years ago. Oh my gosh. All the notes I've had to write, it's just, oh my gosh, what an amazing tool. Yeah.
Or even 5 years. Yeah. AI has just very much come on the scene recently.
Absolutely. It's amazing. Yes. Thank you so much. It's super helpful. Yeah. I think that's going to be really helpful, especially to somebody just starting out. I think those are the lessons we all learn over time, and it's almost like we have to walk that path to be like really great providers, to learn all these lessons. But I love how you just presented them so succinctly like that. It's super helpful.
And those are just mine. Yeah, I think everyone has their own lessons they've learned, but it's been neat to look back and they sound obvious saying them, but when you're in practice, living them is a different thing.
Absolutely. Yes. How would someone find you and get started with what you offer? Stress Free Psych NP. How do they get into this world?
A couple different ways. On Instagram, if a person hangs out there, I'm at Stress Free Psych NP, and I have a lot of tips on how to navigate this framework that I've mentioned, or very clinical tips on prescribing or diagnosing or assessment. Also, my website, Stress Free Psych NP, has a lot of resources there, and so people find me through Google searches as well.
It's amazing. And then your program, is it like open-ended? Is it always something somebody can enroll in, or is it like a rolling enrollment kind of thing?
It is, and people have lifetime access too. And so course gets updated as new, evidence-based treatment recommendations come out. But a person who signs up has it for life and can come back to it because we all have busy lives and schedules. And so it's self-paced to go at your own pace for when you have the time to delve into it and don't have to go through it all at once. You can jump to a module. Let's say you're really not sure how to treat, social anxiety disorder. You can pop into the anxiety module and take what you need, apply it to the patients you're treating, and come back and bounce around to another section. And so it doesn't need to be gone through start to finish, but you can kind of bounce around a little bit too.
Just as you need it. Yeah. And you have lifetime access.
Yeah.
That's amazing. Gosh, well, thank you so much for coming today and sharing with us about these amazing resources. I imagine it's super helpful for nurse practitioners, especially new ones that need that support and education around the things that they didn't learn in school.
Absolutely. Sure thing. Thanks so much for having me.
You're welcome.